I mean, so fatty liver is the deposition of fat into our liver cells. And over time, it's going to cause, of course, a lot of issues because you're going to be damaging the liver and the function of the liver, which is going to really damage everything from our ability to detoxify, to digest our foods. But not, but a lot of times that takes a long process for somebody to get from having fatty liver to to more progressed damage in the liver, where you're starting to see more signs and symptoms. And many times, of course, when we wait until somebody is either in NASH or so let's just back up for a second. So you've got fatty liver, which is steatosis, which is very reversible. And then you have fatty liver with inflammation, which is NASH, which is also reversible. And then it can progress for some people into cirrhosis, which is where where there's scarring in the liver cells, which then can is not reversible. And fatty liver, and then which non-alcoholic fatty liver disease is estimated to be the leading cause of people needing liver transplant by the year 2030. And in the US, right, it used to be that 5% of people needing liver transplant had non-alcoholic fatty liver disease. They're estimating that that's going to be, or now it's actually 25% of the liver transplants are because of that. And as I said, they're estimating that it's one of the major causes, or going to be the number one cause of liver transplant is going to be because of this, which is crazy. And so I mean, why are we not paying attention? I think I don't know the answer to that. So often in medicine, in Western medicine, we are waiting till the shoe drops, right? We are waiting till somebody's really sick and then saying, oh no, what do we do now? Let's transplant the liver, as opposed to saying, okay, let's try to find this early so we can prevent it or reverse it. And which we know we can do, which is phenomenal, right? With both fatty liver and NASH, is truly reversible. And so we need to be paying attention to it. We need to be acting and really, getting involved early so we can prevent this from becoming a real big issue for people. And our children, right? Other statistics that kind of just throw me is that about a third of our boys and a quarter of girls who are obese have signs of fatty liver already. So you can just imagine how that's going to progress, how that's going to impact their overall health, and when are they going to need a liver transplant, right? Yeah. So
I know for a number of doctors who have gone through Institute for Functional Medicine's training, Michael Stone's session where he does on sort of like the reinvigorating the exam, right? The physical exam. And I've seen x-rays of non-fatty liver disease and sort of what that looks like. What would you say from a diagnostic point of view? What do you rely on, sort of in what order, to help you determine whether it's happening or not?
Yeah, so, you're looking at, of course, the liver function tests, the AST and the ALT. So if they're starting to be elevated, you're thinking, okay, could this be because of non-alcoholic fatty liver disease? There are some scores, there's some algorithms where you can put in, many people have used these, the liver function test, as well as some other biomarkers, and get a sense of, does this person have fatty liver? Of course, we are paying attention to signs of metabolic syndrome because that is such a major cause of non-alcoholic fatty liver disease. So when our patients have insulin resistance metabolic syndrome, you've got to be thinking that they could potentially really have some fat deposition in their liver, because really when somebody has insulin resistance, that's one of the things that happens, is the body is not, putting more fat into the liver, and that is, really a major cause of fatty liver disease. So when you see that high waist to hip ratio, when you see a high fasting insulin, when you see a high HOMA-IR score, of course, when you see signs like the liver function tests being high, all of that is raising your flags. On physical exam, when you see things like acanthosis nigricans, which is this velvety appearance in the in the neck area or in the armpit area, or you're seeing skin tags, or your patient has a polycystic ovarian syndrome, or hirsutism if they're a woman. All of these things are making you think insulin resistance. You've got to be paying attention to the liver as well. And then, you can, of course, people, you can do ultrasound of the liver. You can do a test that looks at, the pliability of the liver to, and that's some of the things that we do to determine if somebody has fatty liver. But when you look at those statistics, you're got to be thinking about it for so many people. When we're talking about a quarter of the adult population, right, we've got to be paying attention to so many people's liver. And as I said, from a functional medicine perspective, I think, this is really important to recognize, like everything. I mean, and the research in this area is going in this way. It's a multi-hit model, right? It is not, there's many things that are coming into play. There are many things that can be out of balance that are influencing whether this progresses with one of our patients or not. And so, we just want it to be on our radar, because it has such a huge impact on quality of life. And you don't want to wait until somebody's really in detriment and their liver's not functioning for you to intervene. Because as we know, it's so much easier to intervene when it's early.